Support for Carolina Business Review made possible by Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services, with more than 300 operations in 35 countries, headquartered in Hartsville since 1899. And by Business North Carolina Magazine. There's a place for those who subscribe to the theory that business doesn't have to be boring.
Our government recently authorized a historic health care reform bill. How will that, in the continuing economically challenging times, affect the operation of hospitals in our region and across the country? What will be the overall effect on our access to health care and the supply of health care professionals? Hi, I'm Lori Eberhardt, standing in for Chris William. Today on Carolina Business Review, we host the leader of one of the best hospitals in the country to discuss the ever-changing landscape of health care and its effect on our economy. Please stay with us.
Major funding for Carolina Business Review provided by Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. And by Novant Health, a not-for-profit group of hospitals and physician clinics, ranked as one of our nation's 10 best healthcare systems, caring for patients and communities in North and South Carolina. Major funding also by King & Spalding, an international law firm with over 800 lawyers in 13 offices worldwide, providing legal services to clients in the Carolinas and throughout the world. For more information, visit www.kslaw.com. This edition of Carolina Business Review was recorded August 5th, 2011. On this week's program, Ned Curran with the Bissell Companies, Lynn Bailey of Lynn Bailey Associates, and special guest John McConnell, MD, CEO of Wake Forest Baptist Medical Center. Now, Lori Eberhardt.
Lynn, welcome to the program. Glad to see you.
Glad to be back.
Thank you so much. And Ned, glad you could be here with us.
Thank you, Laurie.
We've got a topic today about healthcare and how it's affecting the effect of the overall economy on healthcare. But first, I'd like to talk about some current economic news. We've recently had a bad spell on the stock market. We've had the worst couple of days since September 2008. And once again, economists are bringing up the concept of a double-dip recession. Are we heading into a double-dip recession? What do you think about that, Ned?
I don't think so. I think we're just kind of the new norm. I think it's going to be bumpy. We're seeing some contraction in government spending at the local, federal, and state level, and we're just going to have to get used to that for a while. So I think this is the new norm. Our business has been very good. We're seeing organic growth of businesses in Charlotte, in the Ballantyne, South Park area. And so for us, we've had back-to-back record years. So we're a contrarian, I guess. Lynn said, I'm sorry to hear that you're a real estate developer when we met outside. And I said, no, actually business has been pretty good for us. But I really do feel pretty good about this area.
Do you think the success of your business and real estate development is localized in the region, or do you think this is a national trend?
No, real estate is a very local business. It all depends on, one intersection to another can make a big difference. So I think we're in the right part of the country. We're in the right part of the region. I think that has a lot to do with it.
That's great. Lynn, what do you think about the whole concept of a double-dip recession?
Well, I'm a dismal scientist. I'm an economist by training. I think we've already started the second dip of the recession, and I think it's simply because we did not initially, in the initial stimulus package 2 years ago, spend enough money, spend it wisely and correctly, and I think that without the stimulation of demand and consumption, I think unemployment rates are still going to stay up. More people we've seen structural unemployment in the economy, which means there are lots and lots of people who now are not ever going back to work in what they worked in, have lost their health insurance benefits, and it's a sinking middle class. And so I think, particularly in South Carolina, that's what I'm looking for in our economy in South Carolina.
So how do you think the unemployment reports that came out today, better than economists expected, but still showing how maybe we haven't fully recovered, how do those affect that analysis?
We would need to do between 250 and 300,000 jobs a month, sustained in order to get us back to where we were. And we're doing about 100,000. And, which is slowing we're not sinking anymore, but we aren't growing. And the only way we can manage entitlement programs and the changes in spending and things that we need to address nationally in terms of our budget is we have to get our economy growing again. And if the private sector hasn't got the traction to do it, then the government still needs to step in and do that consumption and do those expenditures, and I don't see it happening.
And I think when you talk about structural change, that's what we're seeing. Our business is good, but we play to the skilled labor component, college-educated, skilled labor. And when you look at the unemployment rate there, it's under 5%, even on a national basis. So you can just look at our product type and say this is doing well, but yet it's only a portion of the economy. And when you look at the unskilled labor portion, there's some dramatic
it's now
challenges there.
The latest wave of unemployment has hit the public sector, teachers, state and local employees, and those were folks who were protected during the financial meltdown and the employment that followed after that. So now, the public sector, those folks are losing their positions, and they're going to be losing their health care, and that, to me, is what's the next bump.
The next bump that comes. So what type of spending, or how could the government go ahead and put more stimulus in to help build up this basically the middle class?
Well, one of these things that is going to be doing that is health care. I mean, by 2020, the Congressional Budget Office is saying, $1 in $5 in our economy is going to be tied into health care. Health care has slowed its job growth, but it hasn't laid folks off wholesale. There have been, some targeted layoffs, but basically it's been a sector that's employment has been very stable. And in healthcare, you have folks from with a high school education who may work in patient transport, who may work in the kitchen, who may be groundskeepers, to folks with 12, 13, 15 years of postgraduate education and experience in training, So you've got all those levels in there. And information is becoming so critical in healthcare that is a real growth sector within healthcare, is counting and passing the information back and forth to improve the efficiency and effectiveness of healthcare. That's a real growth.
Sure, go ahead, Ned.
Well, when you talk about what can the government do in terms of stimulus money, I'm not sure how much stimulus money they're going to have left to do something with, but I think in addition to talking about what you're talking about is construction jobs. I mean, that's where we really have a soft segment and a lot of capacity. So just get back to infrastructure building, whether it's road building, bridges, could be hospitals, those types of things, but just putting some of that segment back to work and creating some infrastructure that can then help boost recovery even in some of the distressed areas.
Absolutely, absolutely. So using healthcare as a growth, basically a community growth strategy and nationwide strategy.
Yeah.
And then also looking at investing in infrastructure and building up those construction jobs and those other things that are there. Absolutely.
In many communities, healthcare is, if it's not the first largest employer, it's the second or third largest employer in a community. And again, lots of people with lots of skills across a broad array. And so they are good jobs. They're solid jobs. They're jobs that have with benefits. And they're jobs that don't tend to be exported or outsourced overseas.
Thank you so much. We're going to take a break here and welcome our special guest. Yes, next week, make sure you tune in next week for our mayor's show, when we will go ahead and host Anthony Fox, the mayor of Charlotte, Alan Joins from Winston-Salem, North Carolina, and Terrence Roberts from Anderson, South Carolina. Be sure to join us for this very special program. Now I'd like to go ahead and welcome John D. McConnell, MD. In 2008, Dr. McConnell was named as the first Chief Executive Officer in the history of Wake Forest Baptist Medical Center, the largest employer in the Piedmont Triad. including almost 90% of the region's physicians listed among the best doctors in America. McConnell comes to Winston-Salem from Dallas, where he was Executive Vice President of Health System Affairs at University of Texas Southwestern, beginning in 2003. A noted urologist who joined the UT Southwestern faculty in 1984, McConnell held a number of clinical as well as administrative posts at UT Southwestern. McConnell brings to Wake Forest Baptist a philosophy of balanced excellence which has guided his career for 25 years. A native of Independence, Kansas, McConnell earned a BA in chemistry from the University of Kansas and then an MD from Loyola University Strick School of Medicine, followed by a surgical internship and urology residency at UT Southwestern. Thank you for joining us, Dr. McConnell. Welcome.
It's great to be here.
Thank you so much. Segueing from the guest comments into this whole theory of the economic news and a double-dip depression, but also off the comment of Lynn that healthcare often being the largest employer in a region can really be an economic driver. What's your view of Wake Forest Baptist's ability to be an economic driver in that region?
Well, I would agree with the comment that healthcare is recession resistant, but is not recession proof.
Okay.
And because obviously we're affected by the economic tides that are present in the regions that we serve in terms of unemployment, state budgets issues, which ultimately lead to reductions in Medicaid reimbursement, for example. So we are not immune to it, but Lynn is correct. Most, at least large healthcare organizations, have largely weathered the storm. We haven't had no layoffs. In fact, we're still growing pretty substantially. But the other way, you know, as an academic medical center, we have other buffering mechanisms because in addition to healthcare, we have our educational and research enterprise. And especially our research enterprise, even with decline in federal dollars, that is still a very robust economic engine. And many of those discoveries we successfully commercialize and get license income and even startup company equity from. So but we think very broadly about our role in the region as an academic medical center. Healthcare is obviously our most sacred mission, but our other aspects of our mission are equally important as well.
Great, great. Let's talk from a broad standpoint. The Patient Protection and Affordable Care Act that's affected healthcare nationally, how has that changed the business model of what you're doing in Wake Forest Baptist?
Well, of course, big pieces of it have not been implemented yet, and you know, the bill is in some cases still being translated into regulation, and especially in so-called accountable care organizational structures. A lot of that structure has not yet been determined. I'm somewhat skeptical, to be honest with you, because I think that the core issue for America, in my mind, is the cost of health care to businesses. Mm-hmm. And there isn't anything particularly in this act that really pushes all of us to reduce the cost of health care globally. Now, there's unquestionably going to be savings in federally funded programs because they'll be forced into the system. But it's not at all clear how this will really address the larger problem of the health care of the nation. Medicine is an interesting business if you think about it, and I appreciate the understanding of an economist here. As far as I know, it's the only business where we actually don't compete on the basis of value. Value being defined as outcome, an outcome, and the price you pay to achieve that, or the cost you pay to achieve that outcome. You know, buy a new car, you're going to Consumer Reports, and you might be willing to pay slightly more for a car because it has a value or has a certain set of attributes that you believe are worth that additional cost. That's not the way it works in healthcare. We compete on the basis of how good a negotiator we are with managed care, our perceived quality in the community, and our overall reputation. And I think that if anything positive that really comes out of this, it will be trying to get all of this to more value-based healthcare decisions, and that will be good for the country.
Great. Lynn?
The whole impetus of the Affordable Care Act was to expand access to the 30 million or so Americans who have been outside the health insurance system by creating a Rube Goldberg process to allow those folks either in the door through a private exchange to access private insurance or to be accessed to public Medicaid insurance. And if states right now, like the state of South Carolina, is struggling to figure out whether they want to do their own exchange or whether we'll default and go to whatever the feds will create. But there really isn't much. It's a save private insurance. It's a make Blue Cross happy, you know, make Aetna happy, make United happy. It's not about restructuring and redesigning our very fractured healthcare delivery system. So until we get around to restructuring how we produce health services and how we include the patient in that decision-making process, I'm not at all optimistic that we're going to get any savings at all in this.
Do you have a question for Dr. McConnell?
I know that you've been involved for a while in a protracted certificate of need battle, and no other industry really has this process of going to government and asking for permission to do something. And you came from Texas, which did away with certificate of need some years ago. So the difference here back in North Carolina, where there is a strong certificate of need program from a state that got rid of it.
Well, it's an interesting question, and just so the viewers understand this, there is a process that all healthcare facilities have to go through, basically to make new investments in equipment and facilities, and they go through a very rigorous methodology at the state level, and you have to match your request up with what the state has predefined as their need in terms of, does the region need another CAT scanner, does the region need additional operating rooms? And Lynn, as you mentioned, I came from a state that has not had CON for more than 20 years. I actually think it's good public policy because the tremendous growth of, I would say, unnecessary healthcare assets in the state of Texas after CON was eradicated. Overbuilding of facilities, specialty hospitals that really didn't meet any particular healthcare need in the region. And I'm personally not a fan of physician-owned assets in terms of imaging
Those are my
centers.
clients.
Well, I apologize. I apologize, but I think the evidence is actually pretty clear that that leads to increased utilization, and it's one of the 100 things that leads to increased cost of medical care. So I actually think that North Carolina's certificate of need policy is good public policy. I think the fact that litigation follows on the back end of any approved or even unapproved facility.
Oh, you mean the lawyer, healthcare consultant, expert witness, full employment act?
I won't get into that. But I will say I don't think that is a good use of resources. I personally think once the state has made a decision, either up or down on a CON, that it ought to be left at that point. But I think it's good policy.
Ned, do you have a question?
Well, I want to take you back to the new legislation. We have 600 employees, and we look at this legislation, this mammoth legislation coming down the pike, and how are we going to deal with that in terms of providing coverage to our employees? How are you digesting these regulations, and do you see the effective dates slipping in terms of how it affects your business?
Well, I don't know. There's very little mechanism for the slippage of the dates, although I guess that could occur. And I'll tell you what we're doing about it, because we have to manage our way through this uncertainty. And Wake Forest Baptist, and I think most reasonably sized medical centers, we're becoming what we call ACO ready. In other words, we're doing everything we possibly can do to increase our quality and decrease our cost structure. Because no matter what comes out of Washington, or frankly what happens at the state level with Medicaid funding, there is no scenario we're aware of that would not require us to increase quality and decrease costs. And there's very few industries that you're being asked to do both of those things simultaneously. But we're actually optimistic. I've lived through several dire predictions of what would happen with healthcare, and we manage our way through that. And as long as we keep the patient in the center of our radar screen and engineer all of our processes around ultimately the best outcomes for that patient, including prevention, that's how we'll lower cost ultimately. And some of the best programs around the country, actually, as you asked the question, are really public-private partnerships, where a company like yours, who might have a certain number of patients with diabetes, partners with an insurance company and a healthcare provider to create a medical home specifically for patients with diabetes. And the target is actually to prevent hospital admissions. and prevent the need for additional interventions, if you will. The problem with those models, unless they're actual partnerships, is at the hospital level. If you do anything, if you do the right thing in a way to decrease hospital admissions, you have actually shot yourselves in the foot in terms of your economic engine. So one of the interesting parts of so-called healthcare reform is we're being asked to actually change the way we deliver care before the payers have actually changed the way they pay for care.
Lynn, do you have another question?
Well, you're talking about accountable care organizations, and from my perspective, that's just another way of saying staff model HMO.
I don't disagree with that.
And that is not something that in the southeastern United States we have a lot of experience with. We have been groups of various physicians, 5 or 6 in a group, enough to, you know, cover one weekend a month, you know, one night a week on call. And I've seen in South Carolina now, half the physicians in South Carolina have become hospital employees. And I wonder when I go to the doctor, who's my doctor working for? Is he working for the person who's signing his check, or is he still working for me?
Well, I agree with all of your comments, but not necessarily your implied conclusion, at least, about that. You know, because I actually have spent my entire career in an employed physician model. And the Mayo Clinic, the Cleveland Clinic, the Massachusetts General Hospital, virtually all of the top-ranked hospitals in America are virtually 100% employed physicians group. And that's mainly because they're larger academic medical centers like our own. There's no evidence that that leads to decreased quality. In fact, the evidence is just the reverse. And I think it's just the economic forces will drive more employment of physicians by health systems. And I don't actually think that is a bad thing. The level of quality systems that can be brought into place, the group of 5 doctors you described, it's highly unlikely they're going to have the sustainable economics to really have cutting-edge electronic medical record systems that are strongly linked back to the inpatient data sources. Highly unlikely they'll be able to have a nurse whose only job it is to monitor quality within that practice. And those economies can only be garnered on a larger scale, I would argue. So I don't think, I know that many physicians view this as a very bad trend, but I actually think we won't be able to get to where we need to be until hospitals and physicians are tied at the hip much more closely than they traditionally have been.
Ned, do you have another question?
Well, one of the other hats I wear is public policy chair for the Charlotte Chamber of Commerce, and one of the things that came out of this recent legislative session was medical malpractice damage limits and tort reform, and I'm just curious what impact do you think that will have?
I think it will have over an intermediate to long term a very beneficial impact, and this is another experience that I had in Texas where tort reform came into play. Its most immediate impact over 3 years was to dramatically increase the physician supply in the state of Texas. And in fact, the state medical agency that gives medical license in the state was overwhelmed with applications. And they began to able to populate rural areas with physicians where before communities really could not afford to recruit a doc, pay their salary, their overhead, and a malpractice insurance rate that was almost equivalent to A and B. So that was the first impact. It can take several years before you actually see any decline in malpractice rates. As a matter of fact, I've been told that in the state of Missouri, it was 7 years after the enactment of tort reform before they started seeing the rates come down. And some of this is driven by the actuaries and that sort of thing. But I thought that North Carolina reached a very good, reasonable compromise, protecting the rights of patients and preserving, I would say, key aspects of recognizing harm to patients, but actually setting a much more level playing field on a rational basis for preventing runaway jury awards. So I think, again, it was another good policy.
Thank you so much, Dr. McConnell. That's our last word. Thank you for being here, Lynn, and thank you for being here, Ned. Thank you so much.
Major funding for Carolina Business Review provided by Grant Thornton an international accounting, tax, and business advisory organization dedicated to serving middle market companies. Grant Thornton, a passion for the business of accounting. And by Novant Health, a not-for-profit group of hospitals and physician clinics, ranked as one of our nation's 10 best healthcare systems, caring for patients and communities in North and South Carolina. Major funding also by King & Spalding, an international law firm with over 800 lawyers in 13 offices worldwide, providing legal services to clients in the Carolinas and throughout the world. For more information, visit www.kslaw.com. Additional funding provided by Business North Carolina Magazine. There's a place for those who subscribe to the theory that business doesn't have to be boring. And by Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services, with more than 300 operations in 35 countries, headquartered in Hartsville since 1899. And by viewers like you. Thank you. You may write us at Carolina Business Review, 3242 Commonwealth Avenue, Charlotte, North Carolina, 28205.